This episode is brought to you by IndieBase, the smart, simple and budget-friendly electronic patient report system built for the realities of HEMS work and pre-hospital care. Whether you're a solo responder, part of a flexible team or working across a large organisation, IndieBase is the right solution for you. So it works on any device, laptop, tablet or smartphone, and crucially it runs offline when you need it the most. So born from trusted foundation of HEMS base and built by the Medic One systems team, IndieBase combines a familiar intuitive interface with rock solid reliability. So from festival first aid to complex patient transport to high acuity critical care, IndieBase is ready for every pre-hospital scenario. So it integrates with all popular pre-hospital monitors and includes powerful case review and indeed clinical governance modules. So it's ideal for maintaining high standards and supporting services preparing for CQC registration. So there's also a dedicated patient feedback module, which when used alongside clinical governance supports continuous improvement and patient-centered care. So for those working across multiple organizations, IndieBase gives you a personal logbook that unifies your data and even integrates with your HEMS-based logbook. So it's quick to deploy, easy to use and built for the field. IndieBase makes electronic patient reporting simple wherever you are. So find out more at indiebase.net. That's INDIEBASE.net or head to the show notes for further information. This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of pre-hospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're diving into the journey of Zoe Boswell, a dedicated paramedic, mother and community volunteer with Great Western Air Ambulance Charity and or GWAAC. So Zoe brings over a decade of experience as a road paramedic, but also balancing the demands of family life and indeed volunteering with GWAAC's Heartstarters program. So in this episode, what we want to do really is unpack Zoe's pathway and journey to critical care. Zoe is on the last year of an advanced clinical MSc, so Masters in Critical Care. She is studying really in a view to be involved in a HEMS service and indeed within critical care. And what we wanted to do in this conversation is really unpack Zoe's organic journey, her intentionality, and indeed the steps she's taken to end up in critical care. Welcome to the podcast, Zoe.
Good morning. Thank you, and thanks for having me. That's some introduction. I kind of feel a bit not worthy, but yeah, thank you so much for having me here today.
Listen, it's a pleasure. It's a pleasure to have you with us, actually, Zoe. So I wonder if we could just kick off, actually. We'll take many twists and turns in the conversation, but could I just get you to initially speak to your journey into paramedicine? You know, what inspired you to start as a road paramedic?
Well, coming from, a bit of a difficult home life growing up, and I fell into working with horses because it was kind of the path of least resistance, really. So after working with horses for 8 years, I thought I need a change. So circumstances brought me to England and I got a desk job. And I thought, oh, this is great. I'm not out in all weathers and everything. But I'm not really the kind of person to sit at a desk. So the office I worked in was growing. They sent me on a first aid at work course. And I thought, oh, this is quite good. And I actually joined St. John's ambulance service for something to do, where I met a friend, Penny. She was a paramedic in Luton. And I arranged a ride out. And I thought, wow, this is great. I was kind of that keener that was like, at the end of the day, when they were like, I hope we don't get a late job, I was like, no, I want another job. I want to go and do this. And quite an eye opener. an eye opener at how people live as well, just like going out there and seeing it all. So within a year, I thought I got a paramedic pathway in Cambridgeshire. So back when it was not a BSc route, you did do an element with university, but it was mostly on the road and internal with the ambulance trust. So yeah, that's how I found myself on a student para pathway. Um, yeah, and then things took off from there.
Yeah, indeed, indeed. Listen, I mean, that's fantastic because I think sometimes just the entry point is sometimes the hardest, and that initial pivot. And this is a big question, actually, Zoe. Just speaking to your experience really over the past decade, um, could you just maybe just give us some front of mind, just I guess, Roy, just take homes from what's shaped your approach to pre-spot care over the past 10 years. We talk about on the podcast, doing the basics well, always seeking feedback, always yeah, getting the best out of the team by asking, have I missed anything? But is there anything that's really any key learnings that's really shaped your approach to pre-spot care over the past 10 years?
Well, I mentioned I was on a paramedic pathway, and I was very, very lucky. It was the start of the trauma network. So, as a student paramedic, I used to be they called it a transfer and retrieval technician with a HEMS unit. Because we were there to convey patients, say a major trauma patient had gone to a trauma unit, had to be in Addenbrooke's, we would, with the HEMS team, we would go and get that ventilated patient. I would drive the ambulance and we'd transport them to the major trauma centre. It was doing this, I got very involved with the HEMS charity, and I was involved in a lot of their training. And because I was there to do what they call the secondary jobs, they put me on a HEMS crew member course. So I was very, very lucky. There was a handful of us that got to navigate for the medical team when they went on primary jobs, which was amazing. And through doing this role, I was involved with a lot of the training, and it really hit home. You spoke about doing the basics well. I'm a massive, massive purveyor of the primary survey, and I think we live in a very mechanical medicine world at the moment, where a lot of new starters especially just want to get in and put that SATS probe on a finger. And I even had it with someone who's about to get the reg the other day, and I was like, I'll just stop you there. Silver trauma patient. I was like, yeah, we're happy with airway. Can you do a good breathing assessment for me? Listen to that chest, get your hands on. And I think one of the things that really warms my heart that I see with critical care is when they turn up, they take a handover from you and they go, right, no disrespect, I'm just going to do my primary survey again. And it's one of those, we've got to be doing the basics well. And they say, what was it I heard lately? The first assessment should be the best assessment. We don't want to miss things. And I love that, keeping us up to a standard. And I sound very old fashioned and very grandma like when I'm trying to hit home the primary survey. But yeah, I just admire that methodical approach to patients. And yeah, I can't say enough, like, do the basics well. You don't want to look like a complete numpty when you've missed something and then enhanced care turn up and go, yeah, his chest not moving on that side. Does anyone pick that up yet? Or, and also knowing when to move with the patient as well. So doing the basics well, knowing when to call for enhanced care, but also knowing when to go, I need to run with this patient. We can meet them en route if needs be. And a really good example of that, I'd say, is the STAB5 acronym that actually Great Western Area Ambulance clinicians created. And it's not rocket science, but it just hits home. Yes, keep it safe, assessment of that patient, but just get moving, do everything en route they need to the operating theatre. And I just really admire HEMS, really admire that next level of care, whereas we can sometimes let standards slip day to day, but I'm all for trying to bring things up without sounding too old fashioned.
Yeah, no, indeed, no, not at all, not at all. But Zoe, so there is some in absolute. We spoke offline actually about the intentionality of your journey, and actually one of the key facets of intentionality is utilization of education really to help open doors. And And also to your point, get a granular understanding of that aspect of critical thinking and of research and of evidence-based medicine and what the evidence is, or indeed lack of evidence for some of the things we're doing. But could I get you to speak to really just, the master's degree in advanced paramedic practice in critical care, what you've learned through the process, and indeed, yeah, just how it's shaped your perspective on post-op care?
Okay, well, I'm studying at the University of Hertfordshire just now. I've got a lot of friends that have been through that pathway, and I really, really love it. So I wasn't a BSc paramedic. I was one of the last level 6 diploma paramedics, and I knew I didn't want to stand still. I knew um, I wanted to progress in my education, and having that, like being in awe of so many advanced practitioners, and knowing how relieved I am when HEMS turn up when you need them and you've got a really sick patient. I kind of want to bring that to the table for my colleagues and go, oh, someone with more skills or more drugs can make a difference here. So I was very lucky. I did 2 modules at level 7 to prove that I could study to that level, and it's been a modular process. Some modules you feel like you're ticking a box, like research methods. I find difficult, but I know it's really useful for what I'm going on to. But you've got to do. And then one of the most challenging modules was management of the critically ill and injured. Now you've got consultants from London and critical care paramedics from London teaching you, and all of a sudden, I just felt like I know nothing. I am quite a confident, competent paramedic, I like to think, and all of a sudden I just had my eyes open to all these drugs, and there can sometimes be no wrong answer. It's like, okay, so what drug are you going to give and why? And this really knocked my confidence, but I had to keep telling myself, you're not here because you know it, you're here because you want to learn it. And I stuck with it. And yeah, I ended up, I'm in my 3rd year now of my advanced paramedic practice in critical care, and I've got a great deal of imposter syndrome. I've really enjoyed it. It's been challenging. But I think it's bizarre that little old me is going to have a master's this time next year.
No, listen, absolutely, and I just love the intentionality, but also like you said, the feedback that you're seeking, and actually that just continual improvement, which I think is a key facet of every advanced practitioner. Actually, is just that continual improvement every day showing up. Could I get to speak to? So there's a couple of aspects, Zoe, of your again intentionality. That's really around being, a student, a full-time employee. In Southwest Ambulance Trust or Foundation Trust, but also being a volunteer and volunteering for GWAAC, for the Heartstarter program. There's multiple, and being a mum, being a mother first and foremost is probably your most important role. But juggling all these plates, could I get you to speak to just how you've managed that for others that might be going through similar, actually?
Yeah, sure. Well, I'm very fortunate that I'm only 60% hours on the road. I say very fortunate. I love my job. I'd love to work full-time hours, but being a mum, childcare, their father works away, so he's on quite a rigid shift pattern. So I work every other week, basically, which does massively help. And that was a little bit of an inspiration to do my master's, because I thought, well, if I'm only working every other week and predominantly the kids are at school, um, then why not utilize that time? Don't sit back, don't get off the education horse, kind of keep going. Because also I started my master's when I was still a newly qualified paramedic. So, I worked as a tech for many years, something I think is very overlooked. But I've probably had so much more exposure as an EMT, and literally there was a time they didn't have paramedic backup to send you. So sorry, I digress a little bit, but I work 60% hours, which is fabulous for a education point of view. And I've got to utilize breakfast club sometimes. So the Heartstarters, I absolutely love. Although I need to book breakfast clubs and after school clubs, wrap around care for my kids sometimes, it's really worth that effort. Although if you ask me at like 5 o'clock when I'm getting up in the morning to get everything organized, I probably would say, what am I doing? But the Heartstarters I love. And I have to tell you a little story about he'd have been a year 9 little boy. And at the end of the session, we teach them the CPR and about defibrillators. They all get this certificate that's got the doctor's ABC on the back, and they can write their name on it. So this little boy came up to me at the end of a session and with a Sharpie pen, and he said, please, could you just sign my certificate anywhere for me? And I thought, I've made it in life. So the Heartstarters thing, I try to do once a month to go out there. And I think for the kids as well, someone that does it as a job, they love. I wear my uniform when I go to teach Heartstarters, and I think a lot of kids are just a bit like, oh, wow, when you get all the questions, oh, what's the worst thing you've ever seen? But I get a lot of I just get a lot of joy from being able to answer these kids' questions. And one of the other things that I think is sometimes more useful than the teaching them CPR is teaching them the recovery position. That if we've got time in a session, I love to do that, because I always think it's great if you can do CPR, but you're far, far more likely as you get older, you're going out clubbing and stuff, you're far more likely to have to put someone in a safe position. And I just get a lot of joy from doing that. I also, not just my university study, I try to do a lot of the clinical outreach days. So we're very, very lucky in Great Western Air Ambulance. Their paramedics and doctors, so the critical care paras and doctors, give up their time, sometimes paid, sometimes not paid, but they'll give up time, and they create these training days for us. And I will book leave, I will do shift swaps, I will stand on my head to try and access these days, because they're quite often better than some of the university days that I drive 3 hours for and spend a fortune having a student loan for, to drive half an hour to the airbase, do some lectures in the morning and do some sim work in the afternoon. You just can't put a price on this. And I also feel these days are so valuable for newly qualified paramedics as well. So sometimes, the first they know of HEMS is they've got a really sick patient, they're out of the depth, and these guys turn up. So I think it normalizes working with HEMS as well. And it's just good networking opportunities. We're so lucky to have these days. If we don't utilize these days, they'll disappear. So I'm a big purveyor of investing in yourself. So I suppose that's the motivation of using the breakfast clubs to get wraparound care for my kids, to juggle my annual leave, to make it all happen, basically. Putting myself out there. And I learned on my master's about resilience, and we all think of resilience as just keeping going, but actually resilience is utilizing all your resources to get to where you want to be. I'm so fortunate. And another way I can juggle, I've got friends, actually, ex-paramedics that I worked with in East of England. They're retired now, but my friend Kerry, she will jump in the car and she will drive 5 hours to come and look after my children so I can sit exams. I mean, I'm so, so lucky to have some of the right people in my life to enable me to do all the things that I do. And I'd never take it for granted, because, it's not just me. Sometimes the kids are like, oh, don't want to do after school club. Or my eldest, she's a bit like, well, I'm the oldest one there. And I'm just like, do you know what? It's a snack, it's one day this week, and there's a lot of this mummy guilt. There is mummy guilt, but I know I'm doing it to create a better future for these guys as well. As much as I love my job, and I want to advance, I also want to have more options for better income as they get older, so we can go holidays and things. So it feels like you're chasing your tail some days, but when you really want something, you will get up at 5 o'clock, you will book wraparound care, and you will call on friends. And the odd time I've had to go, oh, could you pick the kids up, or like call on somebody. And if you want something enough, you'll find a way to make things happen. And I just never say never kind of thing.
I think
for that.
that's powerful, Zoe, because there's a certain level of intentionality where there is, and also there's probably conscious and or unconscious modeling to your children that actually it takes an extra effort like this to pivot and then specialize, and it's that specialization which is it's demanding and it requires, as you say, kind of an extra commitment, and it's also understanding that, to your point, that education and learning is iterative. There's seeds of wisdom that come from very different places. Some from university, some from some of the open days or the training days, some from feedback. But there's it constitutes learning across the spectrum, really. But it comes at cost, and it's the unhidden cost which you've just explained, which people don't normally necessarily see, but it's
Yeah.
actually worth it in the end because it pays dividends, and this goal orientated action just absolutely comes to fruition once you get that place and once you get the end result. Could I get you to speak? So you've already shared some of your mindset, which is really, like you said, it's about resilience. It's about resourcing almost the local community to help you get to where you need to be, and it's about also the unseen and hidden cost of training, which impacts everything financially, family life, and your own time, accessing those hours in the morning where other people are maybe still sleeping. But could I get you to speak to? We spoke offline about quite a powerful experience of yours, actually, Zoe. It was quite memorable for a number of reasons.
It's been a memorable experience, partly for wasn't a great outcome for this patient, but I'm very passionate about learning from this and bringing around change and just opening people's eyes. So I had a patient who was a tracheostomy patient, and unfortunately they ripped their tracheostomy out of their neck with the balloon. It was a ballooned tracheostomy, and ripped it out their neck. So, and we get this call 3 o'clock in the morning, as you do, no HEMS, and it looked quite a horrific job to be going to, and arrived, and actually the patient was very, very stable, and we did our bits on scene, took the patient in. Patient was very, although they were in a wheelchair, they got themselves onto our stretcher. All was well, smooth journey to hospital. I had alerted the hospital to the fact I was bringing an ENT patient in, tracheostomy. It's quite specialist. I didn't know if they had to call a team in from home to deal with this chap. And I said, I'm not pre-alerting on his condition. I'm pre-alerting that the type of incident that this patient is presenting with. As we arrived at the hospital, they completely deteriorated, hypoxic seizure. I called on colleagues who were great, who got our ramp down. I tried, part of our algorithm is to use a soft suction catheter in the tracheostomy. This soft suction catheter wouldn't go in. Well, the algorithms actually use a bougie, in the absence of a bougie, use a soft suction catheter. So this wasn't progressing into this patient. I just thought, I'm on the doorstep of definitive care. I need to get this guy inside, and I need to breathe as best. This is a hypoxic seizure. I need to breathe as best I can for him. And as I looked at this patient, I thought, because in paramedicine, if all else fails, you breathe for them, don't you? You ABCs. And I looked at this patient and I thought, I'm out my depth here. I don't know what to do, but I need to get him in, and I need to try my best to breathe for him. So trying to use a BVM through the port on his neck, which wasn't very effective, but I just thought, do something while we move into resus. And I shouted at someone, can you let them know we're now a respiratory arrest, hypoxic seizure? As we got into resus, patient arrested. It was very chaotic because they weren't geared up for it. They weren't expecting it. I ended up having to run the arrest. They did manage to get an output back, and unfortunately, my patient died 8 or 10 days later. So for about 3 months after this incident, straight away, it was nearing the end of my shift, straight away I went to speak to management. And to be honest, they were like, I don't really know much about tracheostomy management, but I did an arrest recently, and I learned this is how we try to ventilate them, which wasn't really great. And then I did a lot of research myself. I went into learning development, and actually, yeah, we've got a tracheostomy head. Nobody could find it. And I just thought, well, this re-emphasizes, when did we last train tracheostomy management? I studied our guideline, which is so wordy. I mean, if you go to cardiac arrest and you do an eye gel on a patient, you don't get your guideline out and you read every step, do you? And you're not going to tracheostomy patients all the time. The guidelines are very, very wordy. And I also think we go from the most invasive thing we do as a normal paramedic, as an eye gel, an IV, or an IO, to all of a sudden this guideline says, if all this fails, you can put a bougie into the hole in their neck and you can put a tube in to the first line and you can try and ventilate them from this. And I think, especially if you've not practiced it, it takes a lot of courage to suddenly like delve into someone's hole in their neck. And so I also feel there's a real difference between the GCS3 cardiac arrest on the floor and the patient that deteriorates in front of your eyes. And I think we need to simplify the algorithm that we have. And the other thing with the guideline is it goes from saying never reinsert a patient's tracheostomy to do this, 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 and this. And if all this fails, put the tracheostomy back in. I wouldn't know where to begin. Am I going in the right place? Am I going to inflate the wrong area? And also box of spares. This patient, possibly because he'd pulled out second time in 24 hours, this patient didn't have a box of spares. The carers didn't know even why he had a tracheostomy. There was a lot of poor information coming through right from the start of this job. And I do feel this patient was let down on many levels. I want to do a qualitative piece surveying as many paramedics as possible on their experience, their knowledge, and what they would do with certain situations with tracheostomy emergencies. And I want to try and bring all the information together and try and bring around change, basically. I want, even if it goes back to the old days where we carried cards in our pockets, to have a card that says, right, patient deteriorates in front of you. I know if I was to do that job again, the kind of morbid kind of part of me kind of wants to have to manage a situation like that again so that I don't let the patient down. So I'm very, very passionate about, I direct everybody to the training for tracheostomies. If I had to do that job again, I'd have to get in there with the bougie, get in there with a size 6 tube, and hope that I could ventilate that patient to bring him out of that hypoxic seizure, and then he would never have arrested. And I mean, we'll never know if I could have made a difference that day, but I know my knowledge wasn't where it needed to be. And I never want another paramedic to feel like that, because we're the person that people call when everything's going wrong, right? And I don't want anyone to feel, I don't know what to do. I want them to think, great, I had that training. I know they're deteriorating in front of me. I know I can do this. And so
Yeah.
talk to you all day about tracheostomies.
Yeah, no, definitely. Well, I mean, it's a visceral experience and a powerful one, Zoe, and the learning and the reflection and the multimodal feedback you received actually is powerful. And to your point around reducing complexity, reducing the algorithmic guidance so that there's easy to follow, because like you said, these are they're halo patients, not let alone halo procedures. So you might see, to your earlier point, one a year, one every 2 years, but actually equally as important as to how to manage that patient and feel confident in that. And that's part of the challenge of pre-hospital care, is the outliers and the black swan events that occur, that actually really challenge in every which way. Like you said, and again, it's the night shift, it's 2 or 3 a.m., it's the lack of information around the patient, it's maybe the lack of spares, but again, the lack of interventional information, and then having a patient which can acutely deteriorate on you in the moment. So it's giving credence to all this, and it's bringing these cases into the light where there can be healthy learning. But absolutely, sorry, absolutely. So just as we finish off on the conversation, just a couple of things really. You've already spoken to sort of juggling motherhood and paramedicine, and how how that is, how you have to pay some personal costs. Is there any? I recognize how challenging it is to sometimes have children and then be involved in paramedicine, certainly be involved in critical care, because there is those deep cognitive memories and indeed associations when you have your own kids and trying to treat sick children. But could I get you to speak to really how becoming a mother has influenced your perspective on patient care and managing risk?
Mm. So before I became a mum, it did play on my mind, and I thought, could I still do this job when I've got my own kids? Because for the first 3 years on the road, all I seemed to get was children and trauma. It was a real baptism of fire. And I do think since being a mum, I'm actually a bit more comfortable with managing pediatric jobs. It does open my eyes to be more empathetic towards the parents, and probably I communicate better with parents now, because sometimes you can get so task focused with what you're doing. It's really important to keep them in the loop of what you're doing, why you're doing it. And in fact, I did an outreach, one of the training days just last week with Great Western Air Ambulance, and my role, I was in a team of 3, and actually my role was it was a RTC 4-year-old, car had driven over them, and my role in that scenario was to manage the parent, and oh, they're doing this, they're doing that. And it was just, it's sometimes not the clinical factors, especially with kids. I love just standing back. I like children jobs, because less is often more. Getting mum to strip them off so you can assess them and not upsetting them early on, and all that history taken. So I think my management of pediatric jobs has probably been enhanced since having children. Also, I think as soon as, because when the job comes in, it might say 4 months old and it's a 4-year-old when you walk in. Having my own kids and knowing where they are for their age, I'm very good at guessing a child's age. If I don't have that information, or it will make me question it when I see the kid and I go, oh, he's maybe big for his age or small for his age. But also the risk you mentioned. And I think more and more, so when I started in this job, it was like, you do not put yourself in danger. But I think more and more, we know the job comes with an element of risk, and we're not silly about it. But we've got to know there's an element of risk with what we do. And I think it's made me respect the risks that we take more and more. I have been with mental health patients behaving not very nice. And I have said the words, look, I want to go home to my family at the end of this job. You just need to settle down. And I do think I've got a lot more respect than when I was like back in 2010, when I was carefree, no commitments. It was just like, yeah, let's get stuck in. Let's do it. But now I'm like, have they got a knife? Is the person with the weapon still there? Yeah, I will approach many things with caution in the job, but I do have the thought of my children more in my mind if I know I'm going into something potentially. I mean, you could go into a job and it's not meant to be dangerous and things change as well. But I do think, and that's where I'm grateful for the training, that the trust do a lot on our safety, not putting yourself in certain positions, knowing where exits are, um, body space and things like this. But yeah, certainly being a mum, it's a lot more important to me, the risk that we take. It's a more calculated risk, I'd say.
So Zoe, just to finish off on the conversation, just finally, just wanted to ask really what advice you really give to aspiring paramedics and all critical care specialists really. And just, as in your road and journey to critical care and through your advanced practice MSc, could I get you to speak to really any advice you give to others just balancing life and indeed family commitments and sort of what they should have as top of mind when they're on that road?
Yeah, well, to right basic level, becoming a paramedic in the first instance, I don't think we should be able to just walk out with our degree and bang, you're a paramedic. I think emergency technician roles and emergency care assistant roles are a must. you learn the job before you then top up with your clinical knowledge and take on the responsibility. With progression, I think you've got to put yourself out there. I think you've got to take opportunities. I hear the phrase, "Are the trust paying for it?" quite a lot. And that kind of annoys me, because it's a job where we're always learning, and our commitment to being a healthcare professional, you need to be keeping up to date with your guidelines and your PDGs. And, if you do a job that you didn't know much about, research it. Don't just think, "Oh, I'm at uni, I don't need to do reflective accounts anymore." I mean, I try, when I'm not so bogged down with uni stuff, I try once a month to do a reflective account on an incident I went to, maybe research. And when opportunities come up, take some annual leave, book wraparound care for your kids. If you really want to progress, you'll find a way to make it happen. Call in favours with friends. My friend drove over from Skegness to come down and be with my kids so I could sit some exams. I'll owe her forever. That's something you can't put a price on. But, if you're lucky enough to have people that will support you, you'll find a way to make it happen. I got a last minute call. There were some doctors doing interviews at the HEMS unit, and they needed a crew. And, I was on a day shift. I managed to swap onto a night shift so I could go and be that person that they know if they pick up the phone, I'll make that effort to be there. And you want to be a bit of a go-to person that they know they can call on you, and you'll try and make it happen. Don't be too, I think a lot of people are too rigid. And, I've taken a loan to do my master's, but I think I'm lucky that I don't have the debt of a BSc. That's another thing I'm lucky with. So I've got a postgrad loan. But, if you need to take a small loan, I want to do a pediatric ALS course, and I will have to put my hand in my pocket, but you invest in yourself. I'm not there yet. I've got to be realistic as well. I might not get my dream job, but you know what? I'll have put a lot of effort in, and I'll have worked really hard to try. And if you've just sat back and waited for things to happen, you have to be extremely lucky to get there.
Yeah, listen, I agree. I agree with all that actually, Zoe, and I think that intentionality does go no, it is noticed, and is and it, again, and I hate to say this, but it is part of the journey. Is that it's the journey benefits you as much as the end result, because to your point around seizing opportunities along the way, is there is real adage in that to learn incrementally from all these different experiences, that informs the end result, and it also informs your perspective on critical care in the end, and hopefully the opportunity as it arises. I always say you make your own luck and you create your own opportunities, and it's
Absolutely.
about intentionality. And to your point, it's about being prepared to pay the cost that other people aren't. And a lot of the costs often won't be covered by a service, by an establishment. They have to be borne by yourself. I very much the same as you. Did a master's, had to do it in my own time, had to pay for the majority of it, and had to bear that, if you want to. But it opens doors that you can't even see yet, and it's the beauty of creating opportunities for yourself down the line, which is powerful.
Yeah, absolutely.
Zoe, thank you for your time. It's powerful just to get your first person recollections. It's also powerful just to get your thoughts on and journey into critical care, and just everything that we've just discussed. It's also just fantastic just for other people just to listen, that might be going through similar. So just thank you so much for your transparency, honesty, and perspectives over the past 45 minutes.
Oh, thank you. I really appreciate being given the opportunity to come and talk to you. So I really enjoyed it.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.